All right. Well, good afternoon, everybody, and Happy New Year to all. I'm Steve Higgins, and I want to welcome you to the start, the spring semester, as we refer to it, of the Vermont Center on Behavior and Health monthly lecture series. And so we're in for a treat today. We have Dr. Rick Rawson as the speaker, and as you can see on his slide, he's going to be talking about contingency management as a public health intervention, scaling up CM to treat stimulant use disorder. So by any measure, Rick has had a really distinguished career in addiction science. Rick is actually a native Vermonter here, which has special status in Vermont. I've been here almost 40 years, but I am not a native Vermonter. You have to be born here, and Rick was, and he did his undergraduate and graduate training here at the University of Vermont in psychology, receiving his degrees in 1970 and 1974, respectively. He, in 1974, took a position at UCLA, and he remained at UCLA for, I believe, 40 years, for a long time, returning to Vermont to retire in 2016, but we had different plans for Rick, and to our benefit, he agreed to join the Vermont Center on Behavior and Health in 2016 and has been an important contributor ever since. During that time, he continued to have an emeritus position at UCLA, where he was active and is currently, I believe, as part of that position, he's the scientific advisor for California's groundbreaking statewide implementation evaluation of CM for stimulant use disorder. And I think that's a lot of what we'll be hearing about today. Rick has also played an important leadership role in the Contingency Management Advisory Panel with Wesley Clark, and a handful of others, Mike McDonald, Tyler Erath, John Roll. And they advise SAMHSA and other federal agencies on contingency management, and were very instrumental in the recent development where SAMHSA has increased the amount of financial incentives you can use in a year treating substance use disorder from a very fold to 750 per year, which is a value that the literature suggests would be clinically meaningful, or could be. So Rick has a stellar record of scholarship, as I mentioned at the beginning. Lots of NIH grants over the years, many hundreds of publications, and served on numerous advisory committees of different sorts, both national and global committees. So Rick, thanks for being with us today, and the floor is yours.
Thanks very much, Steve. That was not brief, but I'm gonna give you a set of information today on contingency management as it's currently being rolled out in a number of places around the United States for the treatment of stimulant use disorder. This is something we've been working on for, well, Steve's first study was done in the early 1990s, published in 1991, I think, or maybe 93, reporting that contingency management was an effective treatment for treating people with cocaine use disorder. That was expanded with work with methamphetamine, and it's now being looked at for all sorts of other things. But my focus has been on addressing the stimulant use problem in the United States and around the world with an evidence-based treatment, and contingency management is the one robust treatment for treating people with stimulant use disorder. And as I said, we've had data since the early 90s. Why now is this becoming a more accepted intervention? Part of that is because of this. If you look, these are the overdose deaths in the United States. The different lines are referring to different drugs involved with overdose death. The gold line, you see that goes up in the first part. That's prescription opioids that were the major contributor. But that shifted a lot until you can see two lines now are predominate involved in overdose deaths. The top line is fentanyl. As you all are well aware, fentanyl is the major killer with overdose deaths. But the other line you see that's elevated is stimulants, combination of cocaine and methamphetamine. Cocaine and methamphetamine are involved in some places up to 80% of the overdose deaths. Now, what's not well understood is that, and Tyler Erath has done some work at the syringe program in Burlington. Many of the people who are now going out to seek drugs and inject drugs in most cases get, if they go out to buy the drugs, many of them are looking for stimulants, but they also get fentanyl in the drug supply. The death is often reported as a fentanyl death, and it probably is a fentanyl death. But in many cases, the drug use, purchase and use is driven by their stimulant addiction. And that's one of the things that's really been overlooked in this current response to the overdose crisis. This is data from a colleague at UCLA, Joe Friedman, who has looked at, he's also looked at the data over time. And this graph reflects it the best. These are total overdose deaths. As you can see, by 2021, we're over 100,000 deaths. Of those deaths, 34%, in the toxicology report, 34% just had fentanyl. Another 32%, the purple section, had fentanyl and stimulants. The red part just had stimulants, and the top 18% had neither stimulants nor fentanyl. But if you add the purple and the red sections, you're right at about 50% of the overdose deaths involve cocaine or methamphetamine. Now, it may not have been the fatal agent, or it may have been, but definitely it's clear that unless we address and provide effective treatment for people with cocaine and methamphetamine use disorder, there's a whole bunch of people who are going to remain at very high risk for overdose death due to their stimulant addiction. And so bringing stimulant addiction treatment, effective treatment into the system is going to be an essential part of effectively addressing the overdose crisis. These are data from the state of Vermont. I just wanted to show you in one state here in Vermont. These are data from 2024. The right-hand column is monthly report of the percentage of those individuals who have overdosed, had fatal overdoses in Vermont, the percentage that had stimulants in the toxicology report. And as you can see, in Vermont, it's almost all of them. I mean, it's been interesting to watch. We talk about fentanyl, and fentanyl is certainly worth talking about and worth being concerned about, but it's not the only thing driving the drug use of people who are at very high risk for overdose death. Contingency management is the one treatment that has robust evidence. However, as you know, Steve's first project was in the early 90s. There have been hundreds of projects since. They've all shown contingency management, or virtually all of them have shown contingency management to be an effective treatment. However, we've had trouble getting it into implementation. There have been efforts by SAMHSA and NIDA and the Clinical Trials Network and a variety of others. We had some projects in California in the early 2000s, but there were all kinds of regulatory and other issues that blocked it, as well as sort of an antipathy about the idea of using, actual tangible reinforcers to change behavior. However, I think as the role of stimulants in the overdose crisis has become much more serious, I think people have been less concerned about, their personal feelings about the treatment, and they're looking for something that works, and that's contingency management. It's a behavioral technique employing the systematic delivery of positive reinforcement for desired behaviors incompatible with drug use. In the treatment of stimulant use disorder, the basic paradigm is vouchers or gift cards can be earned for submission of cocaine or methamphetamine-free urine samples, or there are other target behaviors that have been looked at. But the major paradigm we're seeing around the US now is the use of gift cards, generally either physical gift cards or more preferably electronic gift cards, so that we can track them and have good accountability, are delivered when people provide a urine sample tested in a point of care test cup. And when they get the result, they immediately are delivered a gift card worth different values. So CM, these are the essential ingredients. You need to have a specific target behavior that you can measure. In the case of the projects we're talking about, that behavior is giving a urine sample that's tested negative for stimulants. You need to frequently measure the behavior. Protocols generally have patients giving samples 2 or 3 times a week. You need to give them a tangible incentive. In this case, gift cards are the ones we've been using. And if they don't give a sample, or if they give one that's positive for stimulants, they don't earn the gift card. Now, they don't get punished, they don't get sanctioned, they don't get scolded, they don't get kicked out of treatment. Actually, they get encouragement to come in and continue to work on it to earn a gift card on their next visit, but they don't get the card that visit. So contingency management provides a non-drug reinforcer, a gift card, in exchange for evidence of drug abstinence. These small rewards, which it may not sound like it makes sense. I mean, you have people ruining their lives and spending all of their life savings and earnings on cocaine or methamphetamine. Is it really possible these small rewards will change that behavior? And the data says overwhelmingly, yes, it will. There are 2 kinds of protocols that have been used. One is the voucher protocol, first used by Steve in the early 90s. Another model was developed by one of UVM's postdocs who went on to a very excellent career at UConn, Nancy Petrie, and she developed a way of using a variable reinforcement schedule. I'm not going to go through these because there's plenty of data, but there are probably now 15 meta-analyses in the last 5 to 7 years saying something like this. Contingency management, in this case, community reinforcement approach, was the most efficacious and most acceptable treatment, both in the short and the long term. This is another one. Contingency management intervention showed that the strongest evidence favoring outcomes assessed, and so on. Another one, this one was done at UVM, where they showed for people on medication-assisted treatment for opioid use disorder, if those people also had stimulant addiction, contingency management produced great benefits in reducing their stimulant use. Now, incentive programs, the use of incentives, we've done a lot of training around the country, and in many cases we'll talk to people about the use of contingency management, gift cards for behavior, and they go, oh, no, we've been using contingency management now for the last 20 years. And when you ask them what they're doing, they have an incentive program of some sort. Coffee and donuts if people show up for the meeting. They give them a certificate at graduation. Maybe they can get a free soda when they come in for treatment. Or once a month, there's a drawing. And if people have attended 4 sessions in the month, they can go and there's lots of different incentive plans. And we certainly recommend that you bring as much positive reinforcement into treatment as possible. But all these various incentive programs are not contingency management. Contingency management requires a sound empirical protocol and with certain things documented. First, you need an adequate level of reinforcement. Providing a soda or giving people a donut isn't going to change behavior a la contingency management. It needs to be an adequate duration. Most of the research trials have been 12 weeks. The project we're running in California now is 6 months. So the duration needs to be substantial. There's a concern about these gift cards or the reinforcers being somehow diverted or misused or not being effectively accounted for. There need to be clear procedures and practices on how to make sure that there's not fraud occurring. There needs to be a training and implementation plan. This is not a two-hour training program, and then people go and do contingency management. I'll show you the one outlined that's being used at UCLA, which I think is a great model. You need to have adaptations for specific populations. The group at Washington State University has done a wonderful adaptation, an effective adaptation of contingency management for American Indians and Alaskan Natives. There's a group at UCLA that's done an adaptation for treating stimulant use among men who have sex with men. So you need to make sure the CM protocol and procedures around it are effective for specific populations. And there needs to be fidelity monitoring and feedback. The treatment organizations and the people delivering CM need feedback as to whether they're actually doing CM and following the protocol. There's some issues around the money and how the money can be used. We will make these slides available to you, and you can read through this slide. There's some do's and don'ts around things that you should be doing and that you shouldn't be doing in order to make sure you're in compliance with the Office of the Inspector General. I just want to emphasize, in addition to the gift cards that are the critical active ingredient in contingency management, it's important to have the entire experience be wrapped in positive reinforcement. We really want these folks to stay in treatment, first to come into treatment, then are retained in treatment, and earn the benefits of the gift cards. And the entire interchange with patients under contingency management really reflects the importance of positive reinforcement, of acknowledging the patient's participation, their attempts, even if they're not successful in giving drug stimulant-free urine samples. We really want to build a therapeutic alliance, because often it takes people a while to be able to stop their stimulant use to the extent they can give a negative sample. And we want to keep them involved and try to build their self-esteem and build their connection to treatment so that when they're finally able to give that negative sample, they're still participating. So there's a lot of reward and positive interaction that's built into the delivery of contingency management. Now, the big news in the last couple of weeks has been this SAMHSA advisory with getting contingency management into use at such a scale as a public health intervention, so that it's not a little mom and pop intervention that's kind of like a parlor game that, oh, this is great, we really like this, but to really have it be on as broad a scale as possible to impact the overdose death rates. And so we were being hamstrung by having a $75 cap on the amount of federal money that could be used per patient. That's gone away, but with the announcement of this advisory, which was released about 2 weeks ago, and you can get it. That's the link is at the bottom of the page. But really what this says is that using the SAMHSA SOR monies or TOR, Tribal Opiate Response Money, you can now use up to $750 per patient per year. Now that gets the amount up into the range that we think is necessary for contingency management to be effective. And so we can now use SAMHSA money through the SOR grants and TOR grants to be able to support contingency management. This is a big deal. I'd like to thank the folks at SAMHSA who advocated for this, and the other people in the White House who were able to get this policy change made. Keith Humphreys at Stanford, a number of others who have really been working at this. Robert Ballou at SAMHSA, who really shepherded this along through the SAMHSA effort. But this is hopefully going to allow people to benefit and use this technique to reduce their stimulant use. In addition to using SAMHSA funds, some states are using opioid settlement funds. I've had a long discussion with many states where they go, oh, well, we can't use it for stimulants because it's specifically to reduce opioid overdose deaths. True. However, if the opioid overdose deaths are occurring because people go and buy cocaine or methamphetamine and it has fentanyl in it, then maybe if you reduce their stimulant use, you're reducing their risk of a fentanyl overdose. And that seems to have been a winning argument, because we've now seen 3 or 4 states start using opioid settlement funds. And I think they're a great resource. Vermont and specifically is using them. There's other grant funds. I'll give you some examples of other states using other kinds of funds. California, Washington, and Montana all have an 1115 waiver. That is a waiver between the state and the federal government that gives them the ability to use Medicaid dollars for contingency management. And I'll give you some details around that. And then we have some foundations that have been funding contingency management. So what we've tried to do when we had this $75 limit, we did looked in as many doors as we could to see if we could find other ways of supporting CM. And there are some other ways, but now we also have the SAMHSA money as well. When you're developing a CM program, there's a lot of questions and decisions that have to be made. First, these are just a few of them. Which kind of model are you going to use? Voucher or prize models? There's pluses and minuses in both directions. How long are you going to have the program? Many of the studies have been 12 weeks long. Do you think 12 weeks is an adequate duration for working with somebody with a long-term methamphetamine use disorder? In California, we chose to go to 6 months, but that's a decision that has to be made. The target behavior, are you going to use point-of-care test cups and urinalysis as your target behavior or something else? Attendance can be a target behavior, and that's another way CM can be applied. If you're using urinalysis, we've had long discussions about, is it just stimulants you're going to be using as your target behavior or other drugs as well? We've generally recommended, if you're focusing this on stimulant use disorder, that should be the target behavior. How often are you going to see people? 3 times a week, twice a week? It needs to be at a pretty frequent rate. How much are you going to use? What's the schedule you're going to use for increasing the amounts if you're going to, or are you going to use a flat amount? If you start with something like $10 and you increase it with abstinence, which is a generally used procedure, how much are the increments going to be? What are the rules of that piece of the protocol? Use it with other behavioral treatments. There's a lot of decisions that need to be made, and these need to be informed by data whenever possible. Okay, these are the groups that currently are doing work with contingency management, and I'm just going to give you a quick snapshot of these. I'll start with California. I'm going to talk about the VA in a minute, but California's project was started a couple of years ago. The Director of Healthcare Services decided to file a an 1115 waiver with the federal government. I think I wore her down over years of doing talks about contingency management. So when the state of California decided they were going to look at this meth problem and the cocaine problem, they decided they would use contingency management, and they got their federal waiver in, and I think it was approved in 2023 and was started in 2023. I know we're at about 18 months in right now. Tom Fries and Beth Rutkowski run this at UCLA, and they've done a splendid job of designing a training and implementation plan. They used work that Sarah Becker at Northwestern did, where she had documented a model called the Science to Service model for training and implementing contingency management effectively. And Tom and Beth added a couple of augmentations. I won't go into details on it, but it's a great model. And now 18 months into it, we haven't seen, as far as I can tell, and as far as they can tell, any significant issues of fraud or people not being able to do this with fidelity and making sure people who are qualified are doing the contingency management. It's just been a really good implementation. It's made up of this. As I said, we have a 24-week protocol. $599 is the maximum an individual can earn in the California protocol over 24 weeks. That's pretty light in terms of that length of time. But there was a concern in California of the lawyers about giving people more than $600 and whether it's taxable income or so. Anyway, we stayed with $599. They get their reinforcement if their urine tests are stimulant negative. And California hired a company to manage the delivery of the incentives. And that's been a wonderful development. This is the training and implementation plan. I won't go through it in detail, but as you can see, 2 hours of overview, 6 hours of online training, a readiness interview, monthly coaching calls. It's not an insignificant amount of time that's spent on this, but I think it's well worth it to make sure it's done correctly. The incentive manager, Department of Healthcare Services in California, contracted with a company called Q2I, and they've done the incentive distribution in California. And it's been a very big part of the success of the California project has been having an organized delivery of the incentives with the software to make it pretty much a no-brainer task for the staff to deliver the incentives according to the proper schedule and to track them, which is something that the Office of the Inspector General has made clear that if you're going to do this, if you're going to hand out gift cards, if you're going to use this as a strategy, a technique, you need to make sure you've got good accountability. And this is the way we've done that. It's been very effective. The gift cards that people earn in California, they get to choose what they want. They can choose to take the gift card right now or build it up and then take a $100 gift card and buy Christmas presents, which many of them have done. But you can see they have a good array of different things they can purchase through these gift cards. Now we've collected some data. Darren Urata has been in charge of the evaluation of the California project. And I just am going to give you some of the highlights and I do this because I think it has surpassed all of our greatest hopes. This works. This works not only in little research studies or little project. This works on a large scale for, I believe California's about 112 programs now that are involved. As you can see, within about 18 months or 17 months, where we got over 5,000 patients who are participating. And there's a little bit of the last bullet is only 3 weeks. It's not a full month. Actually, the slope of the curve continues to go up. So we're seeing patients being admitted in the neighborhood of 300 to 400 a month, every month, and it's continuing. these are some of the retention data that, remember, our program is that we've outlined is 24 weeks. And we've seen, let's see, I've got a thing that's covering up okay, yeah, 35% have completed the 24 weeks. Now, I don't know how many of you have treated people with stimulant use disorder, but if you have, you know that to be able to get a third of them through a 6-month treatment program successfully on an outpatient basis is pretty good. We also have had another about the same percentage, about a third, that completed 12 weeks but didn't complete the full 24 weeks. About a fifth of them started in, got through a month, but didn't make it to 12 weeks. And about 10% really didn't participate. The mean that they earned during their time in treatment is about $300. And that really fits with the research where we have found that when you have a maximum of, let's say, $1,000, people are going to likely earn about half of it, about $500. Here, $600 maximum, $599 maximum, they earn about, on average, $300. The mean duration of retention is about 18 weeks. 18 weeks, people coming off the street with cocaine and meth use disorder directly into treatment, I'll take 18 weeks any day as retention. One of the things that we've been interested in is, are there groups that this works for and that it doesn't work for? Well, according to these data that we've looked at by these different categories of people, it's pretty much the same for everybody. If you look number of weeks in treatment for white Hispanic, white non-Hispanic, Black, Asian, American Indian, Alaskan Natives, other, is all right in the neighborhood of 16 to 18 weeks of retention. Nobody's showing significant deviation to a lower amount. Men and women, same amount of duration. I think this is a really strong testament to the fact that this is an intervention that works well for people. You may need to tailor it a little bit I think that when we look at these numbers, when you look at the ends, we really need to look at that as an issue of like, how well are we drawing people into treatment? Clearly, American Indian, Alaskan Natives have not been adequately represented in this trial to date. And so these data give us a way of looking at how should we make it more available? Is it not available in their communities? How do we increase access? But it looks like once they get into treatment, their response is pretty much similar to the other groups of patients, which I think is a really positive finding. Urinalysis results are ridiculously good. When people are in this program and they come in and give a sample and it's tested, they're generally negative, 96%, which is very similar to the data from the VA. However, if they're positive, if they've used in the last 2 days, often they won't show up. So you really have to add that in. And if you add in unexcused absences, it makes it about 74%, which means during the average of 18 weeks that they're in treatment, 3/4 of their urine samples are negative for stimulants. That's pretty good. That's a good treatment outcome. If you ask them, did the incentives program help them stop using stimulants? 93% say yes. And then we have some qualitative data. We've done some qualitative data with both staff and with patients. When you ask the staff what they think about this, they say, these are some of their quotes. Earning money themselves allows them to show care and support for others. When they get that incentive, they're proud. Contingency management has filled the gap I didn't really exist. The thing that comes through when you're talking to the staff about what they see with the patients is, I think you could boil it down to they're seeing patients develop some self-efficacy. The patients see this as something where they actually can achieve it. They actually can succeed. Many of these folks who've been addicted to stimulants for years have tried to stop on their own. They've, made efforts, they relapse, they go, and they're not used to succeeding. And one of the things that's really positive to see when you're delivering contingency management is the positivity around patients when they provide a negative sample. And in the context of CM, where we're doing lots of verbal reinforcement, when they do give one that's positive, there's an awful lot of discussion around, okay, well, how are we going to get the next one to be negative? What are you going to do in the next 2 days in order to make sure the next one is negative? There's a lot of focus on how to make this work. We let them know we really want to give them these gift cards. I have said to them, look, I've got a bunch of gift cards with your name on them, and I want to give them to you. So how do we do that? The clients, this is data from them. Giving me an incentive to stop using gave me a reason to not use. The incentive was a reminder not to use every time I had a trigger. Even when I craved to use drugs or alcohol, I knew it would give me a positive test when I went for the incentive drug screen. It made me aware that drug use is going to mess up the good things I have going on in my life. I was starving, and recovery incentives program helped me eat. The gift card supplemented necessities, helped me reduce. I was able to get things and I didn't have to steal. I actually was asked to take this slide out of another presentation because people felt that people shouldn't have to be using these gift cards in order to get things they need to stay alive, which I agree with. However, the circumstances on the street for the patients are, this is what they said. Program kept me accountable for my actions and rewarded my good behavior. Having any kind of attainable achievement for recovering addicts who start from nothing helps build confidence. Remember, these came from the patients. I've been in drug treatment since I was 16. I'm 43. I never passed a drug test until I started here. Blah, blah, blah. You get the idea. And I've done a lot of, as Steve said, I've been doing this for 50 years and spent about 40 years doing work with people with stimulant use disorder. This is really different. The response is really qualitatively different about working with people using contingency management. It's a real positive experience. Limitations, the data are still early. The programs involved were early adopters. They didn't start out all that enthusiastic. Some of them started out pretty skeptical. We don't want to pay addicts to use drugs. However, we've seen a huge flip in the attitude of the staff about that. Let me give you a quick overview of the other, some of the other implementation projects. That was California. We all have a great debt of thanks to Nancy Petrie and Dom DeFilippe and Jim McKay and Gabrielle Kazanoff at the VA. Particularly Nancy. I mean, if it hadn't been for Nancy being persistent and getting contingency management into the VA, it would probably be a dead issue now. We've all been building, all the stuff that I've been doing in the last 10 years has been, in many ways, the door was opened by Nancy getting contingency management into the VA. It's been involved now for, since 2011. They use the prize model, a 12-week protocol. It's been totally in 134 different VA facilities. 88 are currently active. Been about 7,000 veterans that have been treated for stimulant use disorder using CM. They've done a few also with cannabis. As you see, 93% of the samples have been negative. And they're also looking at it for tobacco cessation and medication adherence for people on MOUD. So the VA really was the pioneer in getting this out into the real world. And all of our success currently is based on the fact they were able to do this. The state of Washington was the second state to get an 1115 waiver. They had actually been doing, and Mike McDonald and Sarah Parent and Michelle P. and others in the state of Washington have been doing contingency management. They've got some NIDA grants and have collected some great data. As I said, they were the group that have created the protocol for American Indian Alaskan Natives. So they were doing a lot of contingency management. The old man of the group, John Roll, was a contingency management researcher. So they've been doing this a lot in Washington for the last 10 years through grants and other things. But now they actually have 10 sites active with state funds and 10 that they're going to start up soon and 5 more in Kings County. They've been doing their treatment in a variety of different kinds of settings. They use the voucher model like California does, using providing gift cards and for negative urine samples. Their protocol is 12 weeks long with a maximum earnings of $529. They're going to expand it to $599. They have an approved 1115 waiver that they're about to begin to really ramp it up into a larger protocol. I do think that one of the things that we've been talking about with Kate Hershak from Washington is this American Indian Alaskan Native protocol. If you look at the data epidemiologically in the U.S., the overdose death rate among American Indians is a lot higher than in other groups. And getting this protocol used, I think, is a real priority because a lot of time was spent in actually tailoring it to how to get acceptance, how to get it bought into the tribe. And I think it's an excellent resource that we have not been making good use of. And so hopefully that will get more attention. Montana, in great part because the Washington State folks worked with the Montana folks for about 3 years and did some contingency management using state funds. The state of Montana filed an 1115 waiver, which has been approved, scheduled to start I think March 1st is the early start date. This gives you some of the information, the voucher models being used. Their protocol is 12 weeks long, and UCLA is going to be doing the training for the training implementation for their 1115 waiver program. But Montana has a very large set of Indian tribes that we hopefully will be able to help them bring in the Washington State resources for implementation in Montana. Michigan has, they're a group that is using their opioid settlement funds to start contingency management. Laura Coughlin, who is at the University of Michigan, has been involved with some of the state folks in getting this up and going. Their sites are going to be SUD clinics plus some OTPs where methadone is delivered in a tribal health center. They have an initial plan for 42 sites with 1,000 patients as part of their initial opioid settlement fund target group. They're using the voucher model. Their protocol is pretty much similar to the California one, 24 weeks, $599. They applied for an 1115 waiver, but they're being told that action on that may be delayed. So they're going to try to figure out how to expand the opioid settlement funds until that's actually funded. But Michigan has got a great team to move that forward. The state of Maine, I've worked with the state of Maine now for a couple of years. The group there has now initiated 5 sites. The training is supported by the Maine Office of Behavioral Health. They've used foundation money and a health system grant. Got 5 sites going. The voucher model's used. Protocol is 24 weeks, pretty similar to California. They've treated about 150 people to date. One of the sites, Spurwink Behavioral Health, has a large housing program with people who are unhoused, many of them using methamphetamine. They've gotten a tremendously positive response with that population with their program. They actually did a big thing for the New York Times. It's still yet to come out, but and they're planning to expand to 3 more sites, and that it's been a really positive response. Some of their sites are in Portland. A couple of them, I think, are in Portland, but some are also rural, and so they're doing this in some of the rural communities. Vermont, I think Vermont was the first state to decide to use opioid settlement funds. The committee that oversees these funds agreed in 2023 to award providers funding to be able to do contingency management. They actually started about January of last year. Their protocols are different. There's some variety in them. The maximum in a couple of the clinics is $720 for a 6-month protocol. Most of their sites are using the voucher model. A number of the OTPs are using the prize model of the fishbowl approach. They have 16 sites in total that are underway. Tyler Erath is from University of Vermont, has really been working with the state to help organize this and to get everybody using evidence-based protocols, and things have really gone well. And we don't have a count of patients. I would guess it's about 100 patients so far that have been actively involved in CM to date. There's some others. Rhode Island is using opioid settlement funds to deliver contingency management in OTPs via an app, the Dynamic Care app. New Hampshire has a pilot project in planning. Illinois lists a pilot project from its opioid settlement funds to begin this year. Delaware has an 1115 waiver in process. Clark County, Nevada has a couple $1 million they're going to use out of their opioid settlement funds. So there's a lot of things happening. And with the news this week that you can now use SOR and TOR money, we're anticipating there's going to be a lot more activity. Now, one of the challenges with contingency management is as I said, you have to make a couple of visits a week to the clinic if you're doing in-person contingency management. There are apps that can deliver contingency management virtually. And these are at least 4, there's at least 4 companies. These are 4 of the ones that we're aware of. And as with my list of all the states, there may be others that I don't know about. There may be other states doing things that I don't know about, but we just wanted to give you some idea of the breadth of what's being done, because this is really a breath of fresh air for those of us who did contingency management research over the last 30 years. Seeing the data, seeing the efficacy of this intervention for this disorder, and recognizing there are literally millions of people who have the disorder who don't have it available to them, seeing progress on getting this into implementation has been extremely gratifying. And we hope to see more of it. I just want to put this up. This is something about the fellowship program at UVM that you should be aware of. And I think that's it. I hope to leave 10 minutes, which is just about what's left, for questions. Also, there's my email. If we do questions and answers and you don't have your time for your question to be answered, I'm happy to answer an email with the question.
Great job.
Dr. Higgins, I don't know if we got any questions. No.
Yeah, we do. So let me get you going with them. Other than urine specimens, what are the other examples of target behaviors that could be measured? I think maybe what other kinds of biofluids could be used besides urine?
Well, when we did set up the California project, we got NIDA toxicologist, Dr. Marilyn Hustis, to give us a review of the products that were available to be able to do point of care testing for stimulants. And she's a world expert on that, literally. I mean, she's on the Olympic Committee and does all the drug testing. And she gave us a set of 4 urine tests, your point of care urine tests that she said had good specificity, good sensitivity, gave us about a 48-hour window, detection window, and were very reliable products. And those are the ones we've used in California. And Tyler has recommended those in Vermont, and those are the ones that that are being used. Saliva testing is extremely interesting and promising, and we're asking Maryland right now to take a look at the available products. As Marilyn said, with the point of care urine test cups, there's about 30 of them. She gave us 4 that are good. She said some of them are just junk. They're completely random results. And so that, I think we need to get her review of the saliva test products to make sure before we move forward with that in any great amount, that we know what works and what doesn't work. Now, in the other areas of, I mean, Steve's done a lot of work with tobacco cessation, and there are tests you can use for measuring cigarette smoking results. The Washington State people have been doing work on alcohol, where you can get a test. It's not commercially available yet, but it's in development for a detection window for alcohol that will allow us to use it there. So there's a lot of development of it. Other behaviors include attendance, which is one that some of the Vermont clinics have added to their protocols. One of the things we don't really have time to talk about is the contingency management, a la Steve Higgins and the subsequent studies, has all focused on abstinence as the target goal, that we're helping people stop their drug use, their stimulant use, and get into recovery. Now, in a world of harm reduction, where reducing their use may be a valid goal, how do we do that? How do we use contingency management within that context? And that's something we're working. Maybe you focus on attendance and not necessarily just on the urine test result. Maybe you have a 2-part contingency, attendance and the urine result. So they get a small incentive if they show up. They get a bigger incentive if they give a negative. There's a lot of things that need to be developed, but and I'm sure with the creativity of people using it, but you have to have something measurable. People's attitudes, or their, they really want to get the gift card and they really say all the right things. That's not a behavior that you can use as a metric for contingency management. It has to be measurable and quantifiable. And attendance to a clinic, we have seen people use treatment assignments, people completing treatment assignments, not in the current projects that are underway, but there have been some research with those. So there are other target behaviors that can be used for stimulants and other disorders. Oh, one I should mention that's actually covered by the SOR money is people who are on MOUD. Maybe you want to, I've heard John Brooklyn here in Vermont has talked a lot about having a higher dropout in the first month because patients using fentanyl are more likely to drop out. He wants to use it to see if he can reduce the dropout from the early months of methadone treatment or buprenorphine. So medication adherence, that may be a good target as well.
All right, Rick, one of the attendees wanted to know, they thought using attendance as a target behavior was not recommended because it could be seen as a reward for getting people to use your clinic.
Somebody's been paying attention. Someone's been, yeah. That's an issue that still has a lot of discussion. What Wesley Clark, who was our lawyer expert who understands how the Office of the Inspector General thinks. The concern is that people will develop treatment plans where people have to show up 5 days a week. And if they show up 5 days a week and you can bill all of those visits to Medicaid, that all of a sudden the treatment plans are going to not be based on what's clinically needed for the patient, but on what will maximize the billing. And if you use attendance and you do some kind of ridiculous protocol of visits that is going to generate lots of Medicaid billing, that would be viewed as a problem. Exactly where to draw the line on that is not clear yet. It's still one of the fuzzy areas. The reason Tyler and I have been recommending using point of care urine test results as the metric is we're pretty clear that that's accepted by everybody as a legitimate treatment that doesn't have any problems. The attendance one, some people are using it. Some people think it's more amenable to harm reduction. I understand that. I think it's a legitimate position. I don't know for sure. I'm not a lawyer. We don't do law here, but whether or not that could be problematic, it's not clear to me anyway.
Okay. Do you have any recommendations on best e-gift card providers for CM?
Well, the ones that the ones that Q2I arranged in California provides a whole array of them. In Vermont, Tyler has been directing providers to use something called the PEX card, which I'm not that familiar with, but we certainly do recommend using an electronic. Now, when we use these electronic ones and they go onto people's, phones or PDAs there, that's great. They can also get a paper copy printed out. So it doesn't mean you have to have a phone in order to make this work. You can get a paper copy of it as well. But using the electronic systems really is remarkably helpful you don't want to have counselors with boxes of gift cards in their desks handing out gift cards willy-nilly. That's what the Office of the Inspector General does not want to see happen, because that could easily get, obviously could be problems. I think the PEX cards are a good option. Rechargeable debit cards are also a good option. In California, for the cards there, they have to be not able to be used for purchasing alcohol, tobacco, cannabis, and I think there's one other thing that I don't remember, but weapons. So you can't use your gift cards and go buy an AK-47. So there are some limits on what you can use the gift cards for, but generally they're gas stations, grocery stores, Starbucks, McDonald's, all those kinds of places. Most of the folks we see use them. I mean, the most common is for gas, transportation, and grocery store purchases.
Great. So here's a question. You recommended an adequate level of reinforcement and duration of treatment. How are you defining adequate? Is there a threshold that's consistent across intervention programs?
Yeah, we don't really know. I mean, the California one starts at $10 a year, and I think $10 is the minimum thing that will bing the reward center in their brain. I think if you go below $10, I think we've had some feedback from people who have tried using $5 and they say it doesn't seem to really register. So if you start at $10 and then you incrementally go up with extended abstinence to $25, $30, that seems to be a reasonable range of reinforcers. Another model for that would be to start at $20 and just use $20 straight across. Now, that might bring more people into treatment if you started at a higher amount. So depending on what your priorities are, but you're in that neighborhood of if you go below $10 or if you don't get up to some $20, $30, I think it's really not likely to produce optimal results. You'll get some effects, but I think Carla Rash is just putting together a paper looking at the amounts and data. The data says the more you can provide, the better the outcome is going to be. So The current SOR grant limit is $750 per patient per calendar year. That's probably going to be a pretty good amount. If you stretch it over 24 weeks, and yeah, that would probably be a very reasonable kind of protocol.
Great. Well, Rick, I think we're out of time, unfortunately, but thanks for a really informative, excellent presentation. And I thank everyone who joined us as a participant, as a viewer. And we will be back at it 1 month from now. So keep an eye out for next month's lecture series. So thanks again, Rick. And I think
Thank
that's it
you.
for today.